Hi everyone, good morning. I had a rotten night, some sort of Belgian salmonella. I spent the night with that, trying to get rid of it. So I got to bed at 4:30. But anyway, if I'm not quite as bright as I should be, I've given you my excuse in advance. Okay, Toxidromes, and I'll whiz through them, and obviously feel free to interrupt if you feel the urge or you want to add something, and I'll finish with a few hopefully interesting cases. Okay, what is a toxidrome? Is it too light in here? Could you kindly dim the lights, if you would? Thank you. Lovely. Is it possible? Because it looks very light, doesn't it? There's too much light. I'm prettier in the dark. More? Better? Good? Oh, happy? Okay. I look good. Thank you very much indeed. That's really sweet. Oh, could you turn the light down again? Sorry, it's got a mind of its own. Okay, so it was first coined in 1970 as a syndrome caused by a dangerous level of toxin, but the toxin is now commonly related to drug overdose, poisoning, or an adverse drug reaction. And the brain's most often affected by an acute poisoning, and so clearly, anyone who comes in through the emergency department with altered behaviour, conscious level, or often these are people with a mental health history and they've got sort of bizarre symptomatology, then think drug, or have they taken something, or is it something they're prescribed. And a whole variety of different things. And we'll touch through the various toxidromes, but the patient who comes in with seizures or coma or shock, 2 shocks, arrhythmias, etc., something that doesn't quite fit, there's an odd story, no clear etiology, again, think potential toxidromes. And I'll whiz through these in a bit of detail. These are the main ones, and there are a couple of others I'll add on at the end, but these are the ones I'll touch on. We've got the beta blocker overdose or the insulin overdose or serotonergic syndromes, but the main ones you see are the top 6. There's often an overlap, so life would be boring if it was easy and every patient fell neatly into one toxidrome, so there is often a degree of overlap, and again, I'll touch on that. I found this on the web, which I thought was a really nice picture, and I'll go over this in some detail when we go through the things, but essentially, going along the very top, so you want to look at the heart rate and the blood pressure, the respiratory rate, the temperature, the pupils, the bowel sounds, and are they sweaty or not? And basically, you can break down which of the toxidromes fit looking at these 6 things literally at the end of the bed. So let's start with anticholinergic. Because the drugs are lipophilic, they get through the blood-brain barrier, and so these patients often have neuro symptoms, and they're what's called dry. So they might have the delirium, hallucinations, psychosis, seizures, etc., blurred vision, coma, reduced bowel sounds, dry skin, membrane, so they're not sweaty, fever, mydriasis, flushing, ileus. So basically things that aren't working, they're dry, ileus, urinary retention, etc. They can lead secondarily to high blood pressure, high temperature, tachycardia. And the main drug groups that cause these anticholinergic sort of toxidromes are antihistamines, atropine, antipsychotics, tricyclics, etc. So, again, I'll touch on these things later on as a summary, but you can see the anticholinergic, generally it's brain and dry. On the other hand, cholinergic, they're wet. So they often have confusion, agitation, seizures, etc., neurosigns, and this acronym called SLUDGE, because they're wet, they're excessively salivating, lacrimating, urinating, defecating, getting cramps, and vomiting. So it's quite a nice little acronym, SLUDGE. And as I mentioned, because they're wet, they're often producing lots of secretions, sweating, lung secretions. They get meiosis in the eyes. They can get fasciculations, weakness, and occasionally it can lead on to paralysis. Secondary complications, they may become obviously cholinergic, bradycardic, hypothermic, tachypneic. The main drugs or drug groups that cause it are the carbamates, organophosphates. I'll talk a little bit about sarin and bioterrorism later on, and funny mushrooms that you shouldn't be eating. Hallucinogenic. Again, the patients it's mainly sort of spaced out to, again, neurosymptoms. So they're hallucinating, disoriented, panicky, anxious, seizures, and they're often a bit hyperactive, tachycardic, etc. And again, these are usually recreational drugs like methamphetamine, etc., cocaine, phencyclidine. The opioids, again, you guys know all about the opioids, so I'm sure don't need to go into any detail, but CNS depression, pinpoint pupils, respiratory depression, and they can secondarily get hypotensive, bradycardic, hypothermic, etc. They're usually sometimes found in an alleyway or whatever at home on the floor, on a hard floor. And again, we're thinking, have they got compartment syndrome and rhabdomyolysis? And obviously opioids. And now, especially in the US, I was in Canada, my daughter's in Vancouver, and it's horrible seeing all these fentanyl people just sort of literally GCS3 on the pavement. So it's quite scary. I don't know, has anyone been to like West Coast America recently? Yeah. Have you seen that? It's horrible, isn't it? And it's just they're on the street, just either zombies, walking like zombies, or just GCS3 on the pavement. Anyway, it's the world we live in, isn't it? We've got all the sort of benzos, barbiturates, etc. And again, the CNS depression. They may be confused, agitated, slurred speech. And obviously the danger with these in particular, respiratory depression leading to sometimes apnea, and they can become quite hypothermic. So obviously the sedative drugs, it can happen with anticonvulsants. Do you guys see a lot of GHB, gamma hydroxybutyrate? You're nodding. We do in the UK. It's an interesting drug. It's unfortunately slipped into people's drinks, sometimes knowingly, sometimes not. And they're initially very agitated, and often by the time they come to hospital, they're completely flat out, sort of GCS3, and then they need tubing, and then about, 4, 5, 6 hours later, they wake up, pull the tube out, get dressed, go home, and then repeat it again a few weeks later or whatever. So it's quite an interesting drug. You can get actually quite a severe lactic acidosis with GHB overdose. I've seen a few. And ethanol, obviously, too much ethanol. Next one, sympathomimetic. And again, this is where you've got, obviously, too much catecholamine surge. So these people are anxious, they may be delusional, hyperventilating, paranoid, may develop to seizures, they're sweaty, hyperreflexic, wide pupils, etc., etc. And these patients are often quite hypertensive, tachycardic, and that high catecholamine drive might stimulate tachyarrhythmias. Again, a load of drugs, street drugs, cocaine, amphetamines, etc. And the catecholamine-like decongestants like ephedrine. And rarely, it's been described with salbutamol, but it's not common. There's an overlap, and I mentioned before about overlap. So there is an overlap with anticholinergic toxidromes, but these patients are usually much more sweaty, very active bowel sounds. And I'll touch on bowel sounds later on, because that's quite a useful discriminator. So that's just a summary, and again, which is similar to the pretty picture I showed you at the beginning. This is my less pretty picture I did on PowerPoint. But you can see that there are obviously overlaps, but there are differential signs in these different toxidromes. And I'll walk you through in a second. I think it's coming up now. Yep. So when you get this patient, you're trying to work out what's going on with this patient. Look at the pupil size. Is it pinpoint? Yes or no? Do they have bowel sounds? Yes or no? So if they have hyperactive bowel sounds, pinpoint pupils, etc., suggests that it's more likely to be cholinergic. On the other hand, pinpoint pupils, but the bowel sounds are hypoactive, it's more likely to be an opioid toxidrome. On the other hand, the pupil size may be normal or even dilated. Do they have a temperature, yes or no? If it's high, do they have bowel sounds, yes or no? If it's hyperactive, all these things, high temperature, normal or dilated pupils, hyperactive bowel sounds, it more likely points you to a sympathomimetic toxidrome. On the other hand, you might have normal pupils, a high temperature, but hypoactive bowel sounds, it's more likely to go anticholinergic. The temperature may be normal or low, bowel sounds, hyperactive, hallucinogenic, hypoactive, a sedative, hypnotic. So you can see it's a general rule of thumb. Nothing's absolutely perfect, but I think it's a very quick guide. End of the bedogram, you can work out from pupils, temperature, bowel sounds, what they're likely to have. There are others, and I'll just briefly mention serotonergic. Anyone seen any serotonin syndrome? They can be quite scary. You know, you can get quite often very high temperatures with these patients, extreme sweating, very restless, agitated. They can be very hypertensive. With the temperature, they can get a coagulopathy, rhabdomyolysis, etc., and a whole load of drugs, a lot of like antidepressant drugs. It's been actually recognised with tramadol and fentanyl, and it's seen also with cocaine, and obviously very high serotonin levels, which obviously are hard to measure, especially acutely, and there's often an overlap with the anticholinergic poisoning. But generally, these patients don't have a dry skin that you see with anticholinergic, and the abdomen isn't quiet that you see with anticholinergic. And the final one I'll mention is neuroleptic. Again, mainly due to the sort of antipsychotic type drugs. And I'm sure a lot of these drugs are commonly used by you guys to manage patients with delirium on your ICU. And you do occasionally see these complications, and you do occasionally see quite severe complications. So they might have the dystonias and the ataxias and the extrapyramidal signs, Parkinson's, etc. They can get arrhythmias and classically torsade with sort of haloperidol type drugs, but it can affect the others as well. Anticholinergic manifestations depending on the drug. Again, it can lead to this neuroleptic malignant syndrome where, again, they get really high temperatures. And we're talking, they can go up to 41, 42 degrees or sometimes even higher. And they get a fried brain, they get rhabdomyolysis, they get coagulopathies, and usually these patients don't do very well, even with aggressive management. So the general management principles is, obviously try and work out what's going on. You'll be sending off your blood and urine, etc., and getting a good history to try and find out what the causative drug is. But at the meantime, it's basically good supportive care and repeatedly reassessing them. And you're generally going by their vital signs and their physical exams. So if they have got a temperature that's sky high, that needs to be managed. If they have got a very fast heart rate, that needs to be managed. We'll talk about antidotes. Yep, they can be effective, but they can cause harm. And so it's this balancing act between, on the one hand, yes, if you've got them available and they work, great, but, they themselves can carry issues. Flumazenil, for example, very good at reversing benzodiazepine overdoses, but if the patient's got a sort of pro-epileptic tendency, it can trigger convulsions. Doesn't happen often, but it can do if you suddenly reverse the benzo. So ideally, you're targeting the drug if you know what drug they've taken, and again, we'll show in the next few slides to try and minimise the severity. So are there ways of blocking it? Renal replacement therapy or dialysis to try and get rid of it, bind it, etc. Okay, I'm not going to go through these in any detail, but there's a whole list of specific antidotes, and presumably in each of your countries, like in the UK, there's poisons units, so you ring them up for advice, and they're very useful, very handy. As to, a lot of things are. If you look at the toxicology literature, there are not a huge number of randomized controlled trials, but they garner a lot of experience, and so they can give experience on case series rather than hard and fast evidence, top-level evidence base. But a lot of these things, and again, I won't go to it in any detail, but depending on the specific type of overdose, you can offer the patient a specific use, like sodium bicarbonate, for example, for tricyclics. You get the pH above 7.5, and it reduces the incidence of arrhythmias. The general treatment, so if it's anticholinergic, physostigmine is often used, and often with these patients you might need very big doses. So you're titrating the treatment to the effect, especially on the vital signs. Cholinergic, atropine or pralidoxime if it's severe. For the sedatives and hypnotics, flumazenil for the benzos. Flumazenil also works for zopiclone, and obviously they may need ventilatory support until they're a bit more awake. Opioids, naloxone, I'm sure you're all familiar with naloxone. And now, again, going back to the US, people, I think even school kids now are taught how to give naloxone to people unconscious on the street, which is quite, Roman Piricello, who's at the meeting, I remember him telling me about a year ago that, his 13-year-old son was taught at school how to give naloxone. And now, especially in America, I don't know if it's got into your countries, but they're using inhaled naloxone, so you don't actually have to inject the patient. You can give it by inhalation. So, again, the world we live in. And these people may need lung and cardiovascular support until the opioid wears off. The sympathomimetics, again, depending on the patient, you might need to sedate them with benzos, haloperidol, etc., beta blockade, etc. The alpha-2 effect of low-dose dexmedetomidine has been, again, case studies rather than big series. So, again, it's very much symptomatic relief and trying to at least keep the vital signs at not necessarily normal values, but acceptable values. And serotonergic, again, benzos to calm them down. Cyproheptadine is recommended if it's severe. This, again, won't go through this in any detail, but it's a really good article a few years ago in the New England Journal about sort of chemical weapons and so forth. So, again, they go through a whole load of things where it's been used in sort of terrorist incidents or whatever, and the type of drugs that have been used. So it's actually a very nice article. And again, I won't go through it, but they go through all here, for example, class-specific toxidromes, how these funny agents, these unusual agents, present clinically. Let's go forward. And again, these things often evolve. So you've got the initial toxidrome and the initial treatment, and these things can often evolve. So again, if you're interested in it, I really recommend this article. And on the bottom, they talk about these preventive things. Because sometimes, especially, for example, with nerve gases, etc., the healthcare giver is at risk. And, the danger is you're touching their skin, and then it can get onto your skin. I don't know if you remember, there was, I've forgotten the name of the nerve agent. There was a sort of Russian nerve agent tried on some ex-spies in the south of England. And I think some people walking by, picked up it, I think from memory, it was a perfume bottle or something. And then the woman who picked up this empty bottle, from the outside, actually, I think she died from it. So, again, you've got to be careful as to the agent and how you manage them. And obviously, again, good examples of how you should manage these patients. So, again, recommend the article. I'll finish with a few cases. Sarin was let off on the Japan or the Tokyo underground in 1995. Loads and loads of casualties. This is, in fact... you'll see my name up there. This is ecstasy was actually being used initially in America, but they used it for a different reason. It was sort of people, often students, were taking it in their dormitory room just to sort of make them feel happy. But when it came over, at least certainly to the UK, it was being used more as a sort of dance drug, and so in sort of hot, sweaty discotheques, whatever. They were basically dehydrating, getting very hot, and then taking the ecstasy on top. And we reported actually some of I think the first 3 cases. This is 1992, which shows how old I am. But you can see, I actually can still remember the first guy, the young guy. He was found outside a nightclub, and he was literally headbutting the pavement. He was so agitated and delirious. He was headbutting the pavement. He had a temperature of 43, dilated pupils. He was very tachycardic. He was very rigid. And unfortunately, he was tube cooled, etc. But with all the head banging and the coagulopathy, he bled intracerebrally, and his family agreed for organ donation, but real tragedy at 19. So we had 3 early cases in the UK. I'm finished with this one. Do you remember there was, again in Russia, do you remember Chechen terrorists sort of took over a theatre in Moscow and kept lots of people hostages, and basically the Russian sort of special forces decided that the best way to get them out was to actually put, and it was fentanyl derivatives, and it was actually carfentanil and remifentanil through the air conditioning system of the theatre. And this is a very old, big theatre. It's like several thousand people it could hold. And so obviously, how do you work out how much to give? And obviously it had to be quick enough to knock out the terrorists. But what they didn't do was they didn't actually warn the emergency services that lots of people might be knocked out by the anaesthetic that they were pumping in through the system. And so, unfortunately, quite a few of the hostages were actually killed, because it worked. They stormed the building. All these people were sort of sedated and doped up, but the medical services outside weren't actually prepared for lots of patients who weren't breathing. And interestingly, as you'll see there, because obviously the Russians kept quiet about what they gave and what they did, but there were 2 British survivors. It was a woman and her son who was in Moscow. He was doing Russian as a degree, and he was having a sort of sabbatical year in Moscow, and they'd come to visit him, and basically from their clothing, the British sort of defence establishments worked out that what they gave was carfentanil and remifentanil. The story about that, it was my cousins. So, there's a close to home. And the mother, who was in her 50s at the time, probably 50s, but she actually woke up soon afterwards. I think she woke up when they took her out into the street. But her son, who was 20-odd at the time, he was zonked out and he didn't actually wake up. Luckily he did, but he didn't actually wake up till he got to the emergency department. So, it could have been much more serious. And he did suffer afterwards from PTSD. So obviously opioid overdoses, but you have to support the breathing, naloxone, but they weren't expecting it because they didn't want the Chechens to find out by chance what they were planning to do. And so, unfortunately, there was a lack of preparedness. I'll finish with one other story. Again, he came to our ICU. Do you remember there was an ex-Russian spy who was given polonium? I don't know if you remember that. It was an interesting story. It came in 2006, and basically somebody flew over from Russia and gave him polonium, and I was told afterwards that the amount they gave, had you tried to buy it on the black market, would have cost $20 million, which is quite a lot. And so this guy, sadly, was going to die regardless. But you can see the history that initially he presented with severe vomiting, diarrhea, abdominal pain. He then kept going back and forward to the emergency department, and he kept saying, I'm a Russian spy, I've been poisoned. And they patted him on the head. It was at a sort of community hospital in the north of London, and they said, yeah, you're just being a bit crazy. Eventually he came back yet again, and they did some blood tests and found he was thrombocytopenic. And they go, what's going on here? And then he was neutropenic a few days later, and then he had an aplastic bone marrow. And around this time, he was actually referred to our hospital under the haematologist as he got some aplastic anemia. And he kept saying, "I'm a Russian spy." I was. And his wife was saying, "Yes, he's a Russian spy." He was. Could this be poisoning? And he came to the hospital and he carried on deteriorating with liver function going off, losing hair, etc. And I remember I personally wasn't looking after him directly. I wasn't on that week when he was there. Obviously we have a interesting patient of the week ward round, And guess what? He was the interesting patient of the week. We had a load of the world's media camped outside the hospital. And I heard the story and said, "He sounds like a Hiroshima victim." And my colleague was confident, "Oh, no, they've ruled out radiation, done the Geiger counter, and no, there's no radiation." I said, "He sounds like a Hiroshima victim, with that story of vomiting, diarrhea, bone marrow depression, deteriorating liver function, alopecia, etc." Anyway, he kept on deteriorating. Basically, kidneys went off, got arrhythmias, sort of desquamating, and then he had arrests. And literally just before his final arrest, the cause, the polonium, was discovered. Again, this is my ignorance of physics and radiation physics, but he had alpha radiation. And alpha radiation doesn't penetrate through paper or skin. And so it was detected in his urine. So one of the defence establishments found, the radioactive urine and worked out that it was polonium. So this poor guy was going to die regardless. Now the question is, what do you do for the staff? Do you reassure the staff or whatever? Well, they were actually all very reassuring. It was, you don't need to worry. The risk is very low because it doesn't penetrate through skin, etc., etc. And yes, people were handling urine and throwing it away or whatever, but they said, no, it shouldn't be dangerous. Although, interestingly, they kept him in the room for 3 days because they didn't know what to do with the body, and then they eventually came with a lead-lined coffin. But they said, "Don't worry, it's safe, it's safe," and with hazmat suits to decontaminate the room. "Don't worry, it's safe." Anyway, but, he sadly died, but I don't think, in retrospect, anything on earth would have saved this poor guy. Oh, it's the daisy. I think that's the end here. Whoops, it's coming through. Okie dokie. How am I doing time-wise? 1 minute 56 left. Any questions, please? I'll finish there. So hopefully it's given, an idea of what toxidromes are and a few sort of salty cases to finish off with. Any questions? Easy? It is, but, good old clinical skills. Believe me, there's still a place for good old clinical skills. If I've exhausted you, or time to wake up, or get lunch-ish, no, it's a bit early. But otherwise, thank you very much for listening. Thank you.